A very good morning to all. I'm Dr. Uttara Mohan from IP Digital Media team. We are live on IP India YouTube channel for this webinar. The topic for the webinar is labor and role of physiotherapy by resource person Bishnupriya Pati. The moderator for the session will be Dr. Natasha Pradhan. This webinar is being organized by IP and IPWC Utkal branch. Before we start the session, I would like to briefly update you about our IP Digital Media team. We are a group of physios who handle Zoom platform and live streaming and the IP social media profiles. You can follow IP updates on its social media profiles on Facebook, Instagram, Twitter, LinkedIn, and YouTube. I'll share the links for these profiles in the chat shortly. In the YouTube channel, you can check all our live streamed webinars, which can be played even later. And the playlist section of the YouTube channel has all the webinars segregated in different folders based on various topics. Okay. Now I request Dr. Natasha to please take over.
Good morning, everyone. Myself, Dr. Natasha Pradhan, the Joint Coordinator of IIT Women's Cell Utkal, and on behalf of Utkal team, I extend warm greetings to everyone present here. I would like to welcome and thank Ma'am, President IIP Utkal, Dr. Priyadarshini Mishra Ma'am, State Coordinator IPWC Utkal, for your guidance and support for organizing the webinar today, and even all the Utkal team. I would like to welcome all the seniors, juniors, friends, and colleagues to the webinar. Now, the topic for today's webinar is labor and role of physiotherapist. Now, I would like to introduce the speaker of today's webinar, Dr. Bishnupriya Pati ma'am. She is a consultant physiotherapist, a natural birth counselor, and lactation consultant at the Ankura Hospitals, Bhubaneswar. I would like to welcome Dr. Bishnupriya Pati ma'am, and thank you for accepting the invitation to the webinar. And so I request everyone to be attentive to the session. And as informed earlier, in the quiz session, whoever scores like above 70% of questions will be awarded with an e-certification. Now, without much delay, I would request Dr. Bishnupriya Pati ma'am to lead us and give light on the topic labor and role of physiotherapist.
Thank you so much, ma'am.
Yeah.
Thank you so much, ma'am. Natasha ma'am, Priyadarshini ma'am, all the team member of Indian Association of Physiotherapists and Women's Cell, especially Utkal branch, Dr. Syphilic ma'am. So, Jai Jagannath, everyone. So, am I audible to all?
Yes, ma'am.
Yeah, thank you.
Yes.
So, I could see 47 members are here. So please do let me know if we are unable to know anything, even if it is a very silly things also, I would really appreciate to explain it. Okay, shall we start?
Okay. Yes, ma'am.
Okay, so today is the topic is labor and the role of physiotherapist. So in this, we will see the definition, true and false labor, the difference especially, stages of labor, signs of normal labor, role of physiotherapist in intrapartum or during stages of labor. So for your references, I have kept the link below and might be in two or three more links I have shared. So you can go through the link and I would really appreciate if you people go through it. So next, coming to the definition. What exactly the labor is? It is a normal physiological process by which the fetus and the product of conception is delivered from the uterus to the vagina or birth canal by rhythmic uterine contraction, dilation, and effacement of the cervix. So in this, what we really need to know in the definition, because we are very acquainted with the term labor. Am I right? But here there are certain terms like rhythmic uterine contractions. So what do you mean by that, uterine contraction? Anyone? Anybody would like to add? What is uterine contraction? Okay, so uterine contraction is because we all know the uterus is also, the lining of uterus are made up of so many muscles. Okay, so muscle property is to contract and relax. So during labor, what happens is the uterus, the uterine muscles, they contract. They just get all the muscles, they contract in a rhythmical way. There is no arrhythmic uterine contraction, or else it will be false labor. Okay, so it's an abnormal physiological process where the rhythmic uterine contraction happen. Dilation means opening. Okay, cervical opening happen, and the effacement is thinning. Okay, so uterus, when the uterus, the continuation of uterus is our cervix. Okay, so once the uterine contraction happens, it leads to dilation, means opening of the cervix, and thinning of cervix, okay, which helps to deliver the baby from the uterus to the vagina. And the onset of cervix dilation or opening, it happens from 0 to 10 centimeter by the end of second stage. Next, the point, successful labor. It is very important. For a labor to get success, it really depends on three main factors. That is, one is uterine contraction that I have already informed here. So next is maternal efforts. And the third one is fetal characteristics. So uterine contraction, how does it really goes to produce a labor, successful labor? So uterine contraction, it might be moderate to strong, and it will be rhythmic contraction that helps to push the baby to the cervix and further expelling to the birth station. I'll be telling detail about this birthing station. Okay. And next is the maternal effort. Yes, it is very important because as I have seen in labor, what happens, many people, they're having the idea that inside labor, what we need to do is, that is one thing is push. So if the mother does not know how much force we need to give, okay, that will lead to labor failure, or sometimes it leads to extreme perineal tear. Okay, that's why I have mentioned here, very important. Most mothers gives unnecessary effort that leads to extreme perineal tear. Okay, am I audible? Please do let me know if we are unable to. Yes, please do let me know if I'm going fast. I'll be slowing down. Okay. So next is fetal characteristics. As I was saying, yes, this is very important. The size, if the baby's size, if the baby is 4.2 kg, sometimes what happens, that leads to extreme painful labor. If the baby, ideally the size of the baby, it depends on the weight as well as the baby's head circumference. Okay, the normal baby's head circumference, it has to be 10 centimeter. And that's the reason we have the opening of the cervix from 0 to 10 centimeter. So what happens if the head circumference is more than 10 centimeter? This leads to extreme tear. It might be 3 to 4 degree of tear. If the gynac, if the gynac is seeing the baby's head circumference is more than 10 centimeter, they do episiotomy specially. Okay, so yes, the size of the baby or the fetus is very important. Next is the position of the baby. I'll show you. Yes, we could see this. So here, the baby's position is very much needed for us for a normal labor. So usually to see the normal labor criteria, just the criteria, you could say this is a normal criteria for labor. Okay. So the baby's head has to be down and the leg has to be up. This is called Syphilic or Vertex presentation. Okay. So what is challenging for us is this breeze presentation. In ancient era, the babies, yes, they were taking birth, even they were in the breech presentation, but there were a lot of chances for the baby to get traction injuries, and might be the baby will be having some sort of abnormality, especially from the shoulder, okay, and from the neck area. Okay, so this is wherever the baby is breech presentation. If it is not complete breech presentation, if the baby is partial breech presentation like this, so we can manually mobilize the fetus into optimum birthing position like this. If the baby is completely in the breech by the end of 38 weeks plus, so that might be a little challenging for normal delivery or labor. Okay, and this is transverse. Yes, sometimes in transverse, the baby might take time to move, and yes, this we can move this we can mobilize with some positions, some exercises like kneeling. We can change the baby's position for a cephalic presentation. Okay, coming to the presentation, I have already informed. I have already explained. Next, coming to the number of fetus. So number of fetus, yes, if the mother is having single child, single fetus. So this will be easier to go to the labor, okay? And if the mother is having twins or triplets, so this might be challenging for a normal delivery. So this is the vertex presentation, okay? So usually which we have seen in the labor is most of the babies, they have this LOA, left occiput anterior, okay? And this is very easy to deliver. Which is really challenging is left occiput posterior. That means the baby's head, okay? The baby is facing towards the vagina, okay? The baby's back of occiput, okay? Baby's occiput is near to the coccyx, okay? So this will give extreme pain to the mother, this one and this one, right occiput posterior and left occiput posterior. We do have a chance of normal delivery, but it will be giving a lot of pain in the lower back area, a lot, extreme pain will be seen. So this, yes, we can go ahead with a normal delivery. The success rate is almost 70 to 80%. So next, as I was saying regarding the birthing station, so everybody could see the diagram here. So here, the birthing station specially is described as the place where the baby locates in your pelvis. So by the end of 36 weeks, okay, so we have to fix, as a physiotherapist, our role is to fix the baby in the pelvis, okay, because after 36 weeks, if the baby's head is not in the pelvis, the chances of normal delivery might be less. Okay, so here inside the pelvis, the number ranges from high in the pelvis to low in the pelvis. You can see here, high in the pelvis is -3 and the low in the pelvis is +3. So this 0 we can see, the 0 is the label of cervix. That means after 0, we can explain, yes, the baby is keeping down. The baby is now cervix is effaced. Now we can tell the mother for the pushing. So here you can see complete effacement or thinning and dilation, opening. The baby might be in the low pelvis. That helps to labor down with less time, and opposite takes more time. Opposite takes more time means if the baby is in the high pelvis. Okay. So next coming to true labor. So what exactly a true labor? So true labor is, during this true labor, the contractions we will feel, the contraction, especially the uterine contraction, okay? the contraction will feel at regular interval. So there will be an increased intensity of contraction, like you'll be feeling the contraction is holding along and it is coming with every 10 minutes, like intermittently it's coming. Okay, so then there is shorter interval between the contraction. Like I was saying, every 10 minutes, within every 10 minutes it will come. For some mothers, it might be 15 minutes, 20 minutes. So the discomfort is especially, yes, I want everybody to see this because this will help us to separate or difference between the true and false labor. So the discomfort in back and lower abdomen. Back means especially in the lower back, near to the sacrum area, middle sacral area, and the lower abdomen. So the discomfort does not stop with the walking. It not only the walking, sometimes with the positioning also. Okay, so if this is it stopped during walking or with any position, the pain stops or the discomfort stops, that means it's not a true labor. And the most important is cervix dilated. Okay, in false labor it doesn't. Coming to the false labor, do we have any doubt till now? No, right? Okay, so now, so what is false labor? So when a woman have false labor, so they might experience contraction at irregular, whereas in the true labor, we had contraction in regular interval, like every 10 minutes, every 15 minutes, we are having round the clock, you'll be having irregular interval contraction, that is a false labor. Next, the intensity, it relatively remains unchanged, but in true labor, it was changing and it will become extreme, right? So next is the interval between contraction varies. Sometimes it comes false labor specifically. What my expected mothers they have seen is like after 6 months, like once you are 21st week, 23rd to 24th week, they might feel contraction. Okay, that we say Braxton and Hicks contraction or false labor. So they will feel especially in the lower ab. Okay, the abdomen part only will get tight. So that is nothing but the contraction. So that's okay. It's just a practicing labor or false labor. So you did not worry about. So here, the discomfort primarily in the lower abdomen, as I said, it frequently relieved with the walking and changing or altering position. So there is no dilation of cervix. Okay, whereas in the true labor, we had cervical dilation. Coming to the very important part related to us, this is the stages of labor. So stages of labor, we have first, second, and third. But we do have the fourth stage also. So I'll be telling about this. So coming to the first stage of labor, that is effacement and dilation of cervix. So here in the first stage, we have thinning and opening of the cervix. It starts from here. So what are the characteristics of first stage of labor? There will be a bloody show. What is bloody show? Bloody show, there will be a thick mucus type that will be stained in the blood. It might be brownish or it might be red color in nature. Okay, that will be coming out from the birth canal or vagina. Next is excruciating pain. In the true labor, first stage, there will be excruciating pain, unbearable pain in the lower ab. Some mothers, they feel simultaneously in the lower ab, in the back in the lower back area, and inner thigh. Some they experience in the outer thigh, period kind pain, but in an extreme version. There will be water bag rupture, amniotic fluid will come out. Then the cervix dilated fully at 10 centimeter by full effacement or full thinning. So here this stage is further divided into two. Some they say 3, that is a extra transitional part will be there, initiation of second stage. But I have written it here 2, that is your early labor and active labor. So this first stage varies person to person. Okay, this is a longest part of labor. Okay, so it varies. Why did I say it varies person to person? If a mother, if a woman is first time mother to be, if she is a primary, we say, so for her it will be the early labor or active stage. The first stage goes around 14 to 20 hours. Okay, it might be painful for a first time mother to be, but for a second time, okay, so it is a G2 P1 L1 we say. So is second gestation, for them it might take 7 to 14 hours. Okay, so here is the difference. Why there is a difference? Because their perineum, their cervix, their uterus, they are trained. They already had a baby. They carried. Okay, so the perineal muscles, they might be having a little laxity, or they might be having some sort of loosening, or they are simply trained or open to deliver the baby early. Okay, so here, so this depends, this early labor time period is almost 14 to 20 hours for a first time mother or primary, and 7 to 14 hours mostly for a second time mother. So there will be mild contraction that are 5 to 20 minutes apart and last up to 30 to 45 seconds or more. Yes, so how we calculate this? This first stage is very important for me and for the gynec, because we do not want our mother to come early, because once they come to the hospital, unnecessarily anxiety will be there, nervousness will be there, and at last they will opt for cesarean. So what we do is, we say them what are the golden sign, what are the golden characteristic to visit to the hospital. That is 511. 511. You can write it down. 511. The 5 is every 5 minutes. The 1 is 1 contraction. And next one is for 1 hour. Okay. So if the mother is having contraction intermittently for 5 minutes, like every 5 minutes she is having 1 contraction, that is holding same 30 to 45 seconds maximum or minimum, and round the clock for 1 hour, the mother has monitored, yes, for 1 hour I'm having contraction of every 5 minutes, then the mother has to rush to the hospital. Then we say she is in her active labor. Next, coming to the second stage. So second stage is the stage of fetal expulsion and the delivery. Here we say the mother to push, the pushing stage. Okay. So it happens after full cervical dilation, ends with fetal expulsion. So ancillary force, that is maternal intra-abdominal pressure, very important to deliver the fetus after full cervical dilation. If the cervical dilation is not more than 8 centimeters, the baby might end up with caput. C-A-P-U-T, caput. So what is caput? When the baby's head is stuck in the birthing station, that is 0. Okay, 0 or within +2, the birthing station. Here, okay, the baby's head is stuck between the 0 to 2. That is called caput. So what? So we know So it's not good for the baby, because if the baby comes under stress, if the baby is having caput, the baby might pass meconium. The baby might pass motion, okay, which is not good, because inside uterus, the baby passes urine, not the motion, which is not normal. The baby might swallow the meconium, which is not good. The baby might aspirate and might need NICU or NICU admission. Okay, so the mother, it's very important for the mother to push at the correct time. So here the pushing, the contraction of abdominal muscles simultaneously with respiratory effort with closed glottis. So we know, as a physios, we know that we do the cuffing and huffing techniques, right? Which one is with open glottis and which one is with closed glottis? Huffing or cuffing? Anyone? So here, so cuffing is with the closed glottis, but huffing is with the open glottis, right? And this is what we really need in the pushing stage. The nature of force is just similar like defecation, passing motion, especially just imagine when you are having cough, when you are having constipation. So what we do? During constipation, we just use our abdomen and the respiratory muscle. We just take a deep breath and we hold the breath, right? We hold the breath, and next the time comes for the pushing. So whatever you feel to push, and that time, how the way you push and clear constipation, the same force, the same mechanism works during labor. Okay, so this second stage may last up to 2 hours. The contractions are seen 2 to 5 minutes apart and last from about second. So crowning. Just a minute. Yes. So the crowning is when the point, the baby's head is visible from outside. We could see this area especially. Okay. And this does not go back again. That is called crowning. So crowning is the point which the baby's head is visible from the outside and does not slip back to the vagina between the contractions, especially during the end of second stage. So here, coming to the third stage. So the third stage is the stage of placental separation and expulsion. And yes, here also the intensity of contraction will be there, but less painful than the other two stages. So here the delivery of placental membrane directly after birth lasts for 5 to 20 minutes. Separation is due to disproportion between uterine cavity and placental size. Yes, here we are in the postpartum stage or fourth stage of labor. So yes, postpartum stage especially is the stage from the delivery to the afterbirth, where the mother is examined and taken back to her room. Not only the mother, the baby as well. Okay, the stage of the observation at least 1 to 2 hours post childbirth. So here what we need to check is the gynec and the LDR nurses, they will help with the maternal factors to check the vitals, the pain, the fundus, the perineum, if there is heavy bleeding or not. For the PPH, they will check postpartum hemorrhage. They will see the IV infusion, how is the urine output. Okay. Next, for the fetal factor is once after the delivery, the fetus will hand over to the pediatrician. They will check the Apgar scale, okay, at every 1 and 5 minutes after the birth. So according to them, there are 3 grades, that is 0 to 2 is severe distress, 3 to 6 is the moderate distress, 7 to 10 is the minimal distress, and yes, after this, if they're giving the baby like 7 to 10, then as a lactation consultant, my role is, once my pediatrician say that yes, the baby is completely okay, we take the baby to the mother, we go with the first bonding, that is breastfeeding. Next, so signs. So we all have an idea now what are the signs of normal labor, that is bloody show, contractions, rupture of amniotic sac or water bag, and these 3 are the very important thing. Sometimes what happens, some mothers will be having contraction first, then the rupture, then the bloody show. Some mothers, they will present with first water leakage, then bloody show, then contraction. Some, they don't show anything, they will only have contraction. So this depends, because every pregnancy is different. Okay, so pre-labor sign. So pre-labor sign is lightening. What is lightening? Light means haluka, right? Halka, light. So lightening means suddenly your weight gain will stop. You will feel you have lost weight all of a sudden. You are eating a lot, but you saw there is a there will be a she curve, okay, she curve between your upper abdomen, okay, starting of the upper abdomen and middle abdomen, okay, there will be a curve, but it will be like this at starting. So suddenly there will be a curve. That means your baby has descended, okay, the baby has kept down, the baby slided out. Next is period-like pain or backache, then diarrhea, nausea, or sleeping disturbances also happens, and bowel disturbance also happens. I would like to say regarding about one patient. The patient expected date of delivery was around delivery was after 2 to 3 weeks. So the mother came in emergency complaining of water bag, okay, water bag leak or water leak. So we had our expected or due date of delivery. So we thought what could be the reason. So the mother came and told, I had a lot of biryani, okay, Behruz biryani, it's very spicy, okay. She had, and she was having n number of loose motion timings, okay. So here what we can see is she has diarrhea, and yes, the diarrhea will irritate your bowel, as well as just because your baby, the pelvic floor and your baby is above near to the bowel area. So whatever even if you have diarrhea, definitely you are irritating the uterus by means of irritating your pelvic floor muscles. Okay, so this is the only reason there might be early labor. Okay. So now coming to our part. So what is our role? Our assistance during labor increases the chances of vaginal delivery. During labor reduces the risk of cesarean section and reduce the intensity of pain and anxiety, and reduce the risk of perineal tear, reduces the risk of non-pharmacological anesthesia. You can go through the link. I'll share this one. So here. So in the first stage, I have kept it in the stage-wise management. So in the first stage of cervical effacement and dilation. So here what we need to do is, we will go for a walk We'll make the patient walk. We will make the patient comfortable. And yes, the patient can drink tender coconut, because whatever we do in the first stage, that will give a feedback in the second stage during pushing. So our motto, our goal, it should not be to exhaust or make tired. Okay, the mother should not get tired. We should conserve the energy of mother to help her to utilize that in the second stage of labor. So yes, we can allow the patient, the mother, to go for a walk. We can teach them the breathing exercise, especially the horse sleep breathing. Like this is horse sleep breathing. They can just only focus on making sound, so they can distract from the pain which is coming. Next is changing position. Yes, we can allow the mother to change whatever the position she is comfortable with. And yes, some positions might be squat, some position might be this, some position might be kneeling, some position might be on the Swiss ball, right? So we should appreciate, we should facilitate the mother's position, right? So next is relaxing music. Inside our labor room, that is a NBU, Natural Birthing Unit in Ankura Hospital, what we do is we play music, and we do not keep the labor room as labor room. So there will be a very dim light, music, the mother will really enjoy. Okay, so there, because as a physio, we know the relaxation is very much important. That's why we had the chapter relaxation. So if the mother is relaxed, how the mother will get relaxed? By the light. It should not be very bright. The music, the quality of the music, the pitch of the music, that is very important. Okay. Next is warm shower. Yes. And the warm shower the mother can take if the water bag is broken or not broken. This is okay. This won't cause any sort of infection. But yes, if the mother has broken her water bag, within 4 hours she can take, but after 4 hours she can't. This might increase the chance of risk of infection. Next is back massage. So in back massage, what all things we can give is FURAS, stroking, counter pressure, double hip squeeze. And yes, here we comes is our application of TENS. So continuing, warm compression. The warm compression might be the best to go for the pain relief. So warm compression, where and all we can give is the lower back area, especially in the center, sacral area, the thigh area, inner thigh specifically, and if the mother need is near to the trapezius. Next is inside warm water tub. So water tub, we all know the water helps, the buoyancy of water helps the part to move freely, which we are unable to move in the air. So here water birthing is a type of hydrotherapy that offers several benefits for the mother during the labor and delivery, that allows the mother to move freely and helps to improve the circulation, which helps the baby to move towards birth canal. So inside this is a water birthing setup. Okay, so here this is a water tub. Here there are so many things. One towel is there, their handle will be there. This is a rubber one. Okay, so this is an anti-skid water tub. Here the mother can go inside. The temperature of water should not cross 37 degrees Celsius. Okay, and we need to check the temperature, each and every surface, each and every area surrounding the water tub. Like here, also the temperature should be uniform throughout. So next is the partner support. We do allow the partners, the husband, to stay before the delivery, specifically in the first stage of labor. So what the partner can do is, they can simply give a hug. They can do some exercises. We need to design some exercises with the partner. Okay, so the mother could be comfortable with the partner, and there will be a known face inside the labor room, right? So the mother also will be more confident for the delivery. Coming to the tense. So which tense we need to give? So here we all know how the tense mechanism works, right? So the gate control theory, but during labor, okay, a specific, very specific tense we do use, that is this, eleance, this one. So what is the advantages? The advantage is application of tense along with warm compression. Okay, this is a non-pharmacological pen relieving method, and here it gives some control on your pain. When the mother is in the first stage of labor, she'll be having, what I give is 15 milliampere to mothers. The dosage is for, yes, the dosage is almost 15 milliampere or more than that. It won't cause any harm to the mother and the baby. Okay, and if the mother is taking warm compression along with the tense, I just reduce the intensity of the tense. So still able to move around, it is a pocket tense, so mother can just apply. We can facilitate so many positions. We can alter the, we can frequently change the position, facilitating the optimal birthing position for the mother. Yes, it can be used at home during early labor also. So once you come to the hospital, it has to be active labor. But again, make sure you always check with your gynaec. Next, coming to the massage. So massage is natural pain relieving, helps to relax the muscles, reduce pain by releasing endorphin, helps you and your birth partner, that is me, to connect. Ephuras, stroking, double hip squeeze, counter pressure helps to reduce the pain. So here we know ephuras, stroking and all we know. Just what I want to show you is counter pressure and double hip squeeze. So here is double hip squeeze. You need to place both of your hand, okay? Both of your hand, if here you can see. This is quite visible than this. So both hand, just outer compartment of the hip, and you need to use counter force. This side should not be more, okay? So it has to be equal. So when you give this, you will reduce the back pain, okay? And yes, counter pressure, just keep on applying it over the sacral area. Okay, over the sacral area, you need to use your thinner eminence to use the pressure continuously. And here are certain positions. Here you can use the abdominal lifting, open chest position, lounge. Lounge is very good for the land birthing also. So here you can see all the varieties of positions. Coming to the second stage, here we can do is breathing techniques. The breathing should go with 4 seconds. The out has to go with 6 seconds. Okay. So like whenever you are inhaling in, it has to hold for 4 seconds. And the continuity of breathing out should be 6 seconds. The positioning should be optimum for birth. Like gravity assisted, we do not keep the all mothers for the in lithotomy position. Yes, we give emphasis, we give focus on mother's opinion. So any position the mother want, like side lying position, she want to give birth, or she want to give birth in the squatting pose. She just want to hold the birthing sling and want to give birth on the land, or she want to give birth inside the water tub. So anything. So we need to go with the positioning. Next is perineal massage. Yes, as a physios, we should know the perineal massage. As it train, and it reduces the risk of perineal tear, extreme perineal tear. Pen relief, again in the second stage, you can continue the tense, warm compression. And yes, the education of support is in this part. Whatever we say to the patient won't take. The mothers, they don't take. They will say, I'm the mother, I'm taking pain, you don't know what is going on, right? So for this is the prenatal education and support we could provide. Coming to the third stage, this is completely for the gynec and LDR nurses. LDR is labor, delivery and recovery nurses. So facilitation of placental delivery, we just can be support and uterine massage. Sometimes the gynec wants us to give the massage for the uterus to contract. So here we can help out with the uterine massage. And in the fourth stage, last, that is the postpartum pain management, you can continue the TENS. You can simply give them hot water bag or warm compression. We can facilitate the positions for the breastfeeding. We can give some relaxation exercises. Specifically, Jacobson relaxation is best, what I recommend. Then ambulation. After 3 to 4 hours of stage postpartum, we can start ambulating the mother. The mother must pass urine. So here at the last we are. So the summary. As a physiotherapist, our role has to go by goals wise, right? So the goals are the pain management using the techniques like breathing exercises, relaxation methods, massage, positioning that helps to reduce labor pain eventually. So next is the optimal fetal position, that is our vertex or Syphilic presentation. We can guide the mothers to be for the body positions, exercise on encouraging the best position, but reduce the risk of complication. And the complications specifically include the postpartum hemorrhage. The pelvic floor support, yes, we need to say this one. The pelvic floor support during the delivery, we can't. But yes, during the first stage of labor, yes, we can. So we can just tell when to relax the pelvic floor muscle, when to contract the pelvic floor muscle. Specifically during second stage of labor, the mother must push with relaxation of pelvic floor muscle. If they're contracting, the pelvic floor muscles are not going to allow the fetus, the cervix to open. Okay, so the pelvic floor must get relaxed during pushing. Okay, next. And yes, this is very important for postpartum also. We need to train them for the pelvic floor rehab so that we could prevent pelvic floor dysfunction syndrome. Next is mobility and posture. We assist with movement and postural changes to enhance comfort and promote labor progression. Next is the education and preparation. That this education and preparation go hand to hand antenatally. Okay, so if we have a very good antenatal counseling throughout the pregnancy journey, that only will reflect during the labor. Okay, or else suddenly if we step inside the labor room, the mother is not going to listen to us. Next is postural advice during labor, suggestions on upright or forward leaning posture, labor duration, improve outcomes, how it is important. Then next, the last, physiotherapy empowers women. We females, we do empower, right? Women with tools and techniques that promotes less painful childbirth experience. Yes, without our help. The reason I have taken this class, the reason I choose this class is to empower. Because as a female, I really love this labor. So inside labor, when the gynec, the doctor is directing you, she is leaving hand. Yes, Vishnu, you take care of. I'll go and I'll see my OPD and I'll come. So that is there only, I think, yes, we physios are needed inside labor. Okay, so do not think labor is a very big term. No, this is not. Whatever we do, this is just a specialization. This is just this just needed your active participation and what you think about labor, what you can do inside labor. It's just you who can go ahead with the labor. Okay, so do not cover yourself or you just do not limit yourself. Okay, because life is limitless, and just physiotherapy nowadays is limitless. We do not have any boundary. And here I'm done. Any doubts you can ask? Natasha ma'am?
Thank you.
Ma'am, we can share the questionnaire right now.
Yeah, there is a questionnaire.
As we have 5 minutes, they can fill it up. Only 10 questions are there.
Yeah. Yeah, I would like to request everyone to answer this.
And Bishnupriya ma'am, you can go through the questions which have been put in the chat box and answer accordingly.
Thank you, Dr. Bishnupriya ma'am, for sharing such vast knowledge on labor and how a physiotherapist can handle a patient in emergency and also can carry out an assessment during labor. So I hope all have learned from today's session, and it will be helpful to all in our practice.
Okay, so here Purnima ma'am, Dr. Purnima Rani Panda, she has mentioned like, is it safe? See, the tense which we are using, not during pregnancy, in the labor. Okay, so electromagnetic field, this does not create. Okay, so this tense is very much searched. Along with, we are having a complete control over the intensity, the base and sweep frequency is completely maintained. We do not have to do anything, and yes, it's very, very safe because we have already used, I have personally used inside labor for almost 25 plus patients. Okay, but really, if it is an uncomplicated pregnancy, you should not go ahead. Okay, like if it is a IVF pregnancy, they will give the blame to physios only. Okay, even if there is no chance of any inappropriate thing inside labor, but still, yes, we physios are taking a lot of blame, even if it does not do anything. TENS is very safe, and this TENS is maternity TENS. This is very safe. You can use it. And yes, Dr. Jagat Jaya Sarma has asked. See, here increased relaxin hormone. It does not do anything with the low back pain. Just a minute. Let me see. Okay, yeah. So Dr. Jagat Sharma has asked here. So how to combat with the low back pain due to the increased relaxin hormone? So here, even if there is an increased level of relaxin hormone, yes, you can put inside the hot water, warm water tub in the water birthing setup. This will go eventually. Okay, we have seen a lot of mother who are having raised BP also. Okay, so we say if the BP is raised, the chances of postpartum hemorrhage is more. So we immediately go with cesarean section. Okay, but yes, whatever the scenario, whatever the criticality is there, if the mother is high BP, if the mother is having increased relaxin, yes, the pain will significantly go once you keep inside the water tub. Okay, so next question is, what is the criteria to undergo CS? So Chaturvedi Pilari has asked. Okay, ma'am. So the criteria of cesarean is if there is uncomplicated delivery, like the mother is having uncontrolled diabetes with insulin as well. If the baby is having breast presentation and the baby is not at all moving in the breast presentation, it's continuous till the EDD. Next is if the mother is having IVF and along with twin pregnancy with complications, and if the mother is having uncontrolled hypertension. Once the mother go inside the labor, the BP will further shoot up. So we do not want to take the risk. And if the mother is having unwanted weight gain, okay, so the normal pregnancy weight gain is 8 to 12 kg. If the weight gain is more than 18 kg or 20 kg, that will be a critical thing to go for the labor or normal delivery. They need to go with the CS. And if the baby is having cord around neck, like two pair of two cord around neck, two loop of cord, or more than that, the baby might have birth asphyxia, so they can go for the cesarean. Next. Yes, so here Purnima ma'am has asked which trimester of pregnancy is considered safe to use TENS therapy. So you can use in the middle of third trimester, like after 33 to 34 weeks of gestation. That is safe. Okay. So because if you do use before that, some might say that that is not good. That might say the TENS will increase the endorphin, might be the happy hormones which will facilitate to secrete oxytocin, which is a birthing hormone. Oxytocin is basically a lactating hormone that should not come before the delivery. So that might happen, and the mother will end up with preterm delivery. So we do not want to have that blame on us. So yes, you can use, this is safe when after 34 to 35 weeks of gestation. So first stage pain management SWD, no, we do not use. And yes, if it is a pulsed SWD, we try to keep our mothers away from the diathermic, okay? Because SWD, short wave diathermy, having a lot of complication during pregnancy. That's the reason it's banned in India. But yes, you can use pulsed SWD. And I don't think the mother will cooperate for SWD in that. Because when we are putting a lot of new things, especially we are introducing a lot of new things in front of the mother, it might be challenging to introduce this also. Okay, so we will go with a very simple and gentle techniques to elicit the pain. Say SWD. I didn't get this stance is right answer, but the form it is being said SWD. I didn't get this question properly. Amruta Lade. Amruta ma'am, can you please elaborate what you're trying to say? So are we clear till now? So I hope I have given some idea about what is the role of physiotherapist inside labor, because nowadays this is a growing phase. This is we physios are in every field. So why not inside the labor?
Yeah, ma'am, I'll take 1 second from yours. Hope everybody has filled the form. If you're not getting the form, I can resend in the chat box. Please fill the form. It's a Google form which has your quiz in it. So please do that to receive your e-certificate. As per information earlier, those who score 70% in that quiz, it's only 10 number of questions and you have to get 7 right answers. So it's easy for everyone, I suppose. So you will be awarded with the e-certificate, and we'll take some time, a week or two, to provide you with the e-certificates. So please, everyone, hope everyone has got the form and done with the quiz. If anybody requires again, please send in the chat box. I can again send you the question form. Thank you.
Thank you so much, ma'am. I hope I'm done now.
Yes, thank you. Thank you so much, Bishnupriya ma'am.
Thank you, Priya ma'am. Thank you so much, ma'am, for being there for me when I really needed. Thank you so much, ma'am. Thank you.
So as we have come to an end of the webinar, I would like to thank everyone for attending the webinar, and I hope all of us can apply the information provided to us today and to the people who need our help. So thank you everyone for attending, and we will be going on with webinars after this. Also, we are trying to, and thank you everyone for attending. Thank you so much and have a great day. Thank you all. Thank you all for attending.
I can leave, ma'am.
Yes, ma'am. Surely. Thank you, ma'am.
Thank you so much.